Good morning, everyone. My name is Dr. Mohit. I'm a first year resident here in the Radiation Oncology Department. Today, my topic is going to be about radiobiology of fractionation. The contents of my presentation is going to be consisting of three parts. The first part is going to be the introduction. We're going to talk a little bit about the history of the fractionation, and the second part is going to be about the basis of fractionation, the core arts of radiobiology, and the third content is going to be third one is going to be about the types of fractionation. Introduction. So the multifraction regimens commonly used in conventional radiation therapy are actually consequence because of the largely performed radiobiological experiments in France in 1920 and 1930. Before this, there was a perception that a single high dose radiation is always superior than the multifraction regimens. But a lot of experiments were done to prove that wrong, and one of the experiments which stood out was called as the Gregor experiment. Gregor experiment, they actually took a rat and they tried to sterilize it with a high dose of radiation. So the main goal was to sterilize a rat and see the result. So they postulated that the testes were a model of growing tumor, whereas the skin of the scrotum represented a dose-limiting normal tissue. So when they gave a single high dose of radiation, what they were able to achieve, they were actually able to achieve the sterilization, but they also noticed there was extensive skin tissue damage. To overcome this, they actually divided the radiation and they spread it over a period of weeks. And what they noticed that they were actually able to achieve the similar result that was sterilizing the ram, but this time there was less skin tissue damage. So this actually also is a core principle of radiation oncology, that we want to maximize a tumor kill, and also we want to reduce normal tissue damage. And after this, they concluded that the fractionation of the radiation dose actually produced better tumor control for a given level of normal tissue toxicity than a single large dose. So we can now say that why we need fractionation in radiotherapy. Basically, radiotherapy fractionation is dividing the total dose of radiation over multiple doses for the purpose of tolerability, efficacy, and sparing the normal tissue, and also increasing the tumor cell kill. And the whole fractionation is based on different arts of radiobiology, which are the main core principles behind the radiobiology of fractionation. In 1975, Wither termed a 4 arts of radiobiology, which was repair, resorption or redistribution, repopulation, and deoxygenation. So what fractionation does, it actually helps us to increase the therapeutic index in the radiotherapy by exploiting these 4 R's between tumor and the normal tissue. Later on, they kept on adding more R's to the radiobiology. Right now we have 7 R's, but the one which are marked in red are actually the core basis of fractionation. That would be repair, resorption, repopulation, deoxygenation, and radiosensitivity. If I talk about the first R, that's repair, it's the most important rationale behind the fractionation, because normal tissues and the cancer cells, they have different repair abilities. The fractionation actually takes advantage of this, and they give normal tissue time to heal to decrease the radiation toxicity. And we know that radiation, even a small amount of radiation, can actually damage the cells. So the damage is actually divided into 3 types. So we have lethal damage, which is going to be irreversible and irreparable. And then we have potential lethal damage, which is a component of radiation damage that can be modified by post-irradiation environmental condition. So potential lethal damage can be repaired, but we have to provide an environment for repair purpose. If I talk about sublethal damage, that's the most important one in radiation oncology, because under the normal circumstances, sublethal damage can be repaired. But the only thing is, if we add additional sublethal damage, it can actually form lethal damage. If I talk about repair, as you can see on the right side of the screen, there's a surviving fraction graph. On the y-axis, we have surviving fraction, and on the x-axis, we have R's between the 2 doses. What they did was they performed this experiment in Chinese hamster cells. So they gave a high dose of radiation, and then notice the surviving fraction. So when we give the first dose of high dose radiation, around 15.5 Bq, we noticed the surviving fraction was around 0.005. The blue line is actually curve which we get for the surviving fraction, and the white dots are actually the fractionation, the fractions given at a different time. So when we see the first dot, we can see the surviving fraction is around 0.05. But during the next fraction, the dose of fraction, we can see that the surviving fraction is increased to 0.01. And we know that if we give a certain time to normal cells, they can actually start the repairing, and that's the repair of sublethal radiation. So this experiment basically tells us that if split dose experiment, the result will be the repair of sublethal radiation damage. And it's really important for our normal tissue cells because our normal tissue cells have a greater mechanism for repair. But the tumor cells, they actually have a weaker repair mechanism, which actually helps us to kill the tumor cells. The next R is going to be redistribution. Redistribution is something, it's basically the progression of cells through the cell cycle and during the interval between the split doses. So as you can see on the bottom of the screen, there's a cell cycle. We have different phases of cell cycle, and these different phases of cell cycle have different sensitivity to the radiation. If I talk about radiosensitivity, the most radiosensitive phase of the cell cycle are going to be the late G2 and M phase. And the most radio-resistant phase is going to be S phase. So what radiation not only kills the cells in the sensitive phase of the cell cycle, but also it induces a partial synchronization. So what's partial synchronization? So let's say if I give the first dose of radiation, I'm going to kill the cells in G2 and M phase. But the cells which are in the resistant phase of the cell cycle, the S phase, or maybe resting phase of the cell cycle, that's G1 phase, are going to get accumulated. So during the time of next fraction, the cells will actually transfer from the resistant phase to the sensitive phase, so that we can actually kill the cells in the next fraction. As you can see on the right side of the screen, there's another surviving fraction graph, and we can see that during the S phase of the cell cycle, the surviving fraction is increased, and in the M phase of the cell cycle, we can see that surviving fraction is decreased. So redistribution of proliferating cell population throughout the cell cycle increases the cell kill in fractionated treatment relative to a single session treatment. The next R is going to be repopulation. So in between the two doses of fraction, there's the normal cells, and as well as the tumor cell, they will actually try to repopulate. And for normal cells, we want normal cells to actually repopulate because we want our normal cells to get repaired. But for tumor cells, this is a big problem. So fractionation, we should always control it. So we should not allow it too much time for excessive repopulation of tumor cells. At the same time, for not treating so fast that acute tolerance is exceeded. So in a basic words, I can say that the longer the radiotherapy course is going to last, more difficult it will become for controlling the tumor. This is because of something known as the accelerated repopulation. So whenever we give radiation or any cytotoxic agent, the normal phenomena for the cell, the surviving cell, will be to actually divide. But what happens in accelerated repopulation is that it triggers, there's a trigger which actually allows the cells to even divide faster than before. If I take an example of head and neck cancers, usually it starts in about 4 weeks of the initiation of fractionated radiotherapy. If I talk about the treatment we usually give conventional radiotherapy, and it usually lasts between 5 to 7 weeks. So it's a big problem for us because if the patient in the last phase of his treatment try to default, or for some reason he doesn't want to continue the treatment, this accelerated repopulation can be a big problem for us. So the implication will be that the treatment should be completed as soon after it has been started, and it's always better to delay the treatment than to actually introduce delay during the treatment. In this graph, we can see the 3 R's simultaneously. We can see the first sharp increase in the surviving fraction. It's actually because of the repair of sublethal damage. And then we can see the decrease in the surviving fraction. It's because of the result minor repopulation, because we are actually able to kill more cells now. And the third sharp increase in the surviving fraction is the reason, the main reason is the population. So how well the cells survive depends on the timing of radiation doses. So waiting long, about 6 hours, can make them more sensitive, while shorter or much longer gaps allow them for better survival. Next R is reoxygenation, and it's a really important R for us because oxygen is actually a really good radiosensitizer, and we know that oxygen can help us kill more cells. It's also important for the normal cells too, because if the cells are oxygenated and they're getting good environment, nutrient environment, we know the cells will repair much nicely and better, and they will perform the better function. But for tumor cells, it helps us to actually cause more radiation damage. As you can see on the right side of the screen, there's a tumor cell. Some part of the cell is irradiated cells and some are hypoxic cells. If I talk about radiosensitivity here, the irradiated cells or cells which are oxygenated are actually more radiosensitive. So if I give radiation, if I give a single dose of radiation, I can kill only irradiated cells, and what I'm going to be left behind is with the hypoxic cells. But if I add fractions, or different fractions in the treatment regimen, I can actually first kill those irradiated cells, and I can give a certain amount of time to tumor cells to actually get reoxygenated, so that in the next fraction, I can actually even kill more cells, because after reoxygenation, these cells are going to actually get the oxygen, and hence they will be more radiosensitive. So if the radiation is given in a series of fractions, separated in time sufficient for reoxygenation to occur, the presence of hypoxic cell does not really influence the response of tumor. Next R is radiosensitivity, and I feel it's integrated in most of the R's of radiobiology. So different tissues, different cells will have different radiosensitivity. Either it's intrinsic sensitivity, some cells will be more sensitive, some will not. We will have cell cycle dependency, as we have discussed. The layer G to an M phase are more radiosensitive, and S phase is more radioresistant. It's oxygen enhancement ratio. We have well-oxygenated cells which are more radiosensitive. So radiosensitivity is basically integrated with the other R's. If I talk about summary of R's and compare the normal tissue and tumor cells, the repair and repopulation are really in favor of normal tissue, because it helps the normal tissue to actually get repaired fastly and easily. And if I talk about tumor cells, the resorption, deoxygenation, radiosensitivity actually helps us to kill more tumor cells. If I talk about repair, we want our normal tissue to get repaired after radiation damage. And if we give enough time for if we give enough time to normal tissue is going to repair nicely. Because this is the reason, because they have a good repairing mechanism. If we compare with tumor cells, they have a weaker mechanism, and they're not going to repair as nicely as the normal cells. So eventually they're going to die. If we talk about resorption, the normal cells in resistant phase will survive, because if I say some cell survives and they go into the resting phase of the cell cycle, they will get enough time to actually repair than the next dose. The tumor cells, obviously in the sensitive phase, are going to likely die after the radiation. The repopulation and normal tissue will regenerate after radiation exposure to restore the function. But here's the big problem for us, because tumor cells will try to repopulate between the radiation dose, and it can actually reduce the treatment effectiveness. Next one is reoxygenation. We have already explained that the well-oxygenated normal tissue will experience less hypoxia and can maintain their function, and the tumor cells, it's beneficial for tumor cells because the hypoxia cell can survive, but if we give enough time for reoxygenation, we can actually kill the tumor cells. Next thing I want to talk about is radiation response, because response of all normal tissue to radiation is actually not the same. And depending on the response, we have divided it into early responding tissues, and then we have late responding tissues. The early responding tissues will be constituting of fast proliferating cells, such as skin, mucosa, intestine, and epithelium. And the late responding tissues will have large number of cells which are going to be in resting phase, spinal cord, bladder, lung, and kidneys. And this is really important for us in radiation oncology, because we actually decide the dose and everything according to them. If I talk about radiation response, the early responding tissues can actually tolerate higher total dose if fractionated. that makes them less sensitive to the changes in fraction size. And if I talk about late responding tissue, they're actually higher sensitive to the total dose and can be very sensitive to the large fraction size. If I'm changing the fraction schedules, and if I'm even decreasing the schedule or increasing the dose, I'm going to affect the late responding tissues. In other words, if I can say that prolonging overall treatment time actually spares the early tissue, because there's going to be no effect on that, but it's actually going to have a great effect on late responding tissue. So prolonging over time within the normal radiotherapy range has little sparing effect on late reactions, but a large sparing effect on early responding tissues. Here's a cell survival curve for late and early responding tissues. As you can see on the right side of the screen, there's early responding tissue and late responding tissue. The blue one is the late responding, and the red one is the early responding tissues. And most of the tumors actually comes under the early responding tissue, which I will talk later. You can see the late responding tissue has a shoulder and it's more curvy, and the early responding tissue doesn't have that curvy nature. And this curvy nature is actually because of the difference in the repair capacity of this early and late responding tissue. And this curviness can be defined by something called as linear quadratic formation, which can be further explained with the help of alpha beta ratio. So what's alpha beta ratio? On the right side of the screen, we have cell survival curve, where we are comparing the effect and the linear quadratic relation. As you can see, the first part of the curve, it's actually kind of linear, and the next part is a little bit curvier. The linear and the quadratic are two different components of the cell killing. If I take an example of DNA, we know there are two strands of DNA, and if we give a single high dose of radiation, and we we can achieve the damage to both strands of the DNA, we can actually kill the DNA in a single kill. So that will be cell killing due to single hit. If I give first dose of radiation and it actually kills the one strand of DNA, actually damages the one strand of DNA, and on the next dose of radiation, I'm actually damaging another strand of DNA, then it's causing the cell death. We can call it cell kill due to double hit. So alpha beta ratio will be defined when the linear component of the cell kill, which is alpha, or cell kill due to single hit, is equal to the beta part of the curve, which is the quadratic component, or maybe we can call it cell killing due to double hit, are equal. So alpha equals to beta gives us the alpha beta ratio. And it gives us, the significance of this is that it gives us the measure of sensitivity of particular groups of cells to the fractionation. So a small alpha beta ratio means the large sensitivity to change in fractionation. And the large alpha beta ratio means lower sensitivity to changes in fractionation. As we had talked earlier, that the late reacting tissues are actually sensitive to the changes in fractionation. So if I say early responding tissues, they have higher alpha beta ratio, meaning that they have low sensitivity to the changes in fractionation. But if I talk about late responding tissues, they have a lower alpha beta ratio, and that means they are largely sensitive to changes in fractionation. So this actually helps us to choose the type of fractionation, because if alpha beta ratio of tumor is same or less than that of the critical normal tissue, then a large dose per fraction is preferred, which we call as hypofractionation. And if the alpha beta ratio of tumor is high and is more than the alpha beta ratio of normal tissue, a low dose per fraction, that would be called as the hyperfractionation, is actually preferred. There are a lot of various fractionation schedules. So we have conventional and then we have additive. If I talk about choosing a perfect fractionation schedule, it not only depends on the alpha beta ratio, but it also depends on a lot of other factors. It can depend on the type of tumor, type of person we are treating, the condition we are in, the availability of machines. So a lot of factors comes in when we have to schedule the fractionation. Conventional is the most convenient one, which we use nowadays, and the additive one has different schedules, and more research has been done, more schedules have been introduced. If I talk about conventional fractionation, in conventional fractionation we actually give fraction size of 1.8 gray to 2.2 gray. That's one fraction per day and 5 fractions per week. By giving only 5 fractions per week and giving 2 days of rest, it's really convenient for us and as well as the patient. It's really efficient and effective, and it also helps. It's the most tried and trusted method, and both tumoricidal and tolerance doses are well documented. The best part of conventional fractionation is because it actually achieves a balance between the response of tumor and the early late-reacting normal tissue. Because I've studied in the arts of radiobiology that the multiple fraction spares normal tissue through repair of SLT and apopulation of cells, and concurrently the fractionation increases the tumor damage through reoxygenated and redistribution of tumor cells. So the next type of fractionation is hyperfractionation, and the duration of this fractionation is basically similar to the conventional fractionation, which will be approximately 5 to 7 weeks. But what we do here is we actually give more fractions per day, so we can give 2 to 3 times per day. And the benefit of this is to actually improve the therapeutic ratio. When I talk about therapeutic ratio, it's probability. It's a correlation between the probability of tumor control and the normal tissue toxicity. So what it does, it reduces while we're reducing the dose given in each fraction, we reduce the late effects while also permitting an increase in total dose to the tumor. So hyperfraction really benefits us in head and neck cancers, but again, it depends on the type of tumor and the patient while choosing the fractionation. And a lot of trials have been done to compare the hyperfractionation and the conventional fractionation. And one of the trials which is very famous is was done by the URDC 22791. So they compared, it was a randomized control trial, so they compared conventional fractionation with the hyperfractionated regimen. What they found out was that the hyperfractionated treatment there was a significantly improved 5-year local tumor control in hyperfractionated radiotherapy, and the trend was actually towards the improved survival. In this particular trial, there was similar kind of acute and late toxicities, but in a lot of other trials we have seen that there was increase in acute toxicities. The main problem with the conventional and the hyperfractionated regimen is that they have a time period of 5 to 7 weeks, and we have studied that accelerated repopulation kicks in just after 4 weeks of radiotherapy regimen. So to combat that, they introduce another regimen which is accelerated treatment. So what they're doing here, they're actually reducing the population and rapidly proliferating tumors by reducing the overall treatment time. There's another trial which compares conventional with the accelerated fractionation. So we're trying to actually complete the treatment in just 5 weeks as comparable to the conventional fractionation, which is done in 7 weeks. In the results, we can see that the accelerated fractionation has a better local region control with p-value of 0.02. The specific survival showed a trend in favor of accelerated fraction arm. But the problem here is that if we try to treat the patient in a shorter amount of time, we're actually increasing the dose. If we're increasing the dose, we are actually increasing the toxicity. So a lot of toxicity was seen in the accelerated fraction regimen. Even the late effects were seen in the accelerated fraction regimen, which were even lethal. So next regimen was START, which was continuous hyperfractionated accelerated radiotherapy. And this regimen was given with 1.5 pair dose. It was given 3 times a day, 6 hours apart, and 7 days a week. So no off on weekends. So total dose of 56 gray were given in 36 fractions over 12 consecutive days, including the weekends. So we are just finishing our treatment in just 12 days. And it's actually beneficial for us because we are being a little bit aggressive. But the problem here is that if we change too much of fractionation, we're going to actually lead to the late effects, because we have studied that late reacting tissues are really sensitive for the change in the fractionation. So if we are trying to beat the accelerated repopulation by just completing the treatment in 2 weeks, we are actually inviting more reactions. And it's really not convenient for the patient to come for 12 consecutive days and get 3 times a day fraction, and it's a big hassle for us too. A trial was done in which START was actually compared to conventional conventional radiotherapy. It's a randomized controlled trial. So there was actually no difference in the local regional control, but we have seen that the acute radiation mucositis was more severe with the chart and was occurred earlier but settled sooner. And the skin reactions were less severe and settled more quickly, and there was reduced late morbidity. This is a split course regimen. It's basically for the elderly patients who are getting radical treatment for cancer bladder or prostate or lung cancer. What we do is we actually divide the two halves with a gap in between, with interval of 4 weeks. It's just for the elderly patients so that they can actually recover from acute reactions of treatment. The next one is hypofractionation. So, as the name says, hypofractionation means we are giving less fractions. But again, the problem here is going to be that if we're decreasing the fractionation, we are increasing the dose. So high dose is actually delivered in 2 to 3 weeks. And the rationale behind this is that we're completing the treatment in a shorter period of time. The higher dose actually gives us the better control for larger tumor, but again, the same disadvantage is that it's a potential for late tissue complications. If I compare the types of fractionation, we can see that conventional and hyperfraction are, the duration of treatment is kind of similar. But if we try to reduce the duration of treatment in chart, we are actually reducing the dose per fraction because we are giving more fractions per day. But if we compare it with the hypofractionation, the time duration is kind of similar or reduced, but the dose per fraction is actually increased. And this actually helps us to figure out the disadvantages of different types of fractionation. In conventional fractionation, the rationale is that we are actually achieving the balance and it's the most convenient. There are well-documented late and acute toxicities, and the disadvantage here is that long treatment can lead to accelerated depopulation. And similar goes for the hyperfractionation too. If I talk about chart, we're doing this to overcome accelerated depopulation, but again, there's a chance of acute toxicity. And it's not suitable for all tumors of the patient, obviously, because of the toxicity. And the next one is hypofractionation. Usually we do it for the tumors with low alpha beta ratio. That would be tumors with, example will be the breast and the prostate cancer. The effect on the acute tissue will be lower, and the effect on the late tissue will be standard or higher. But again, the disadvantage is that there's a higher late tissue toxicity, and that's a problem for us. If I conclude my presentation, the radiobiology of fractionation is fundamental to optimize radiotherapy, balancing tumor control with normal tissue sparing. Fractionation not only improves the tumor response, but also reduces toxicity, making it cornerstones of modern radiation oncology. And as we're using those core radiobiology principles behind it, we're actually able to achieve it very sooner. And as research advances, personalized fractionation protocols will continue to shape the future of cancer treatment, involving both efficacy and